Hello, everyone. I'm Dr. Will Gray, and in today's episode, we're going to talk about osteoarthritis. Before we get started, please like, follow, share, subscribe, comment, let us know what you want us to talk about, or if you're enjoying the material that we're releasing. And with that being said, let's get going. Today's content, we're going to cover 4 different pieces of osteoarthritis. We're really going to talk about it from a PT standpoint, but I kind of wanted to educate you all a little bit before we get to it. The discussion of the treatments. First piece, we're going to discuss what is arthritis. Second part, we're going to talk about grades of arthritis. And then third is the symptoms. And then 4 is treatments. So, what is osteoarthritis? Basically, it's the cartilage at the end of the bones wears away over time. You may have some bony growth that develops, which is basically bone spurs for the most part, and then decreased joint space. Those are pretty much the 3 classical things that they are looking at, or as well as what happens with osteoarthritis. The grades, there are grades, 5 of them to be exact, and I kind of sort of simplified them a little bit to give some definitive differences. Grade 0, normal knee, there's nothing going on. Grade 1, minor bone spurs, possibly. Minor cartilage breakdown. Grade 2, some joint space or some joint pain, maybe arise, stiffness and discomfort. Grade 3, cartilage erosion occurs around the ends of the joints. And then grade 4, no joint space. This is very severe. You have a lot more spurring, a lot more cartilage erosion. There's a lot of bad going on here. And with that, these symptoms kind of sort of follow, but not all within every grade, too. I think a lot of times we get caught into arthritis is pain, 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 pain. That's not necessarily true. Arthritis is a lot more stiffness than we probably realize, but there is some pain with or with activity, depending on the grade of the arthritis or the progression of it. You have joint stiffness in the morning. That's one of the key classical signs that you will run into joint stiffness, right? Popping of joints is a thing, or that grinding of the joints, but the swelling that accompanies the joint popping or the pain itself is something that you will see a little bit more of when your arthritis is pretty advanced. But the joint stiffness is what I like to kind of focus on initially, because there's a transition that happens here. Now, the treatments. This is the part I'm going to linger on for a little bit. So just, stay with me. The non invasive approach, over the counter medications, PT, MFR, soft tissue work, modalities, ice, heat, stem. And then you have the invasive piece, the joint replacement, steroid injections, right? I'm going to talk about this backwards a little bit. I know I have them set up left to right, but let's talk about the invasive approach. Joint replacements, right? For a total knee replacement, you have to hit a certain amount of markers before that even occurs. And what I really want to talk about is what it does. I don't think it gets mentioned enough, and I don't think patients understand it. I think patients think that once you have the knee replacement, things and pain and everything tends to go away and disappear, and things get easier, and that's the farthest thing from the truth. When you have a joint replacement, they're basically cutting off the end of your tibia and your femur and replacing the whole joint or the end of the joint, where the cartilage will basically erode from, or the quote unquote part of the joint that's very painful. Doing this procedure is a very, very, very intensive procedure. It's a lot of stuff that's going on while you're on anesthesia. And with the cutting of the bone, with bone being the most highly vascular, high innervated, thing in your body, they have to put certain medications into play, nerve block the area. A lot has to occur. Now, after you get out of that procedure, then you have a pretty long journey for recovery. People try to put a time frame on let's say 8 to 12 weeks, as far as getting from point A to walking again and back to all things you want to do and not having any issue. For me, it's really dependent on the client. There's a certain level of unawareness that you see that the client has from a wound care standpoint, where they're not taking care of the actual incision. Although they'll put that 7 to 14 day dressing on top of it to seal it off, there's still some things with the wound that I think are being missed a lot of times. The other thing is also the rehab. I'm not sure what has happened with the progression of the rehab or how they kind of sort of go about this. I think everybody gets thrown on the bike and they ride it for 10 to 15 minutes, and that's their ranging piece. They do have some heel slides, some hamstring stretches, and things like that, but there's not enough manual therapist to patient treatment going on. And I know why. I get it. I mean, it's the time crunch. Like, which is what really hurts the patient. We're kind of in a place where the quality slash optimal return to care has diminished greatly. So when I'm saying this is really to educate the therapist as well as the patient, which is your range of motion is paramount in the first 4 to 6 weeks. I don't care if you don't get any strength. I could care less. If you cannot bend and stretch your joint to a certain quote unquote range of motion, you know, depending on, your quote unquote surgical procedure, and did they offset the knee a little bit to 5 degrees and extension to be able to let the joint last a little bit longer or whatever, right? You have to hit certain landmarks early because that knee starts to heal and it starts to heal very quick. And with that happening, once you can't range it, it doesn't matter what you do strength wise, doesn't matter what you do modality wise. So when they're doing the invasive procedure for the joint replacement, please do not be underneath the perception that your joint is going to be 1,000% better. After the replacement, there's still a lot of hills and mountains you have to climb to fully get that joint to obey you. Okay. Now, with that being said, there's also some pieces of it that need to be remembered, right? Some pieces. And what I mean by that is that we need to make sure that we're taking better care of our joint replacement after the joint replacement procedure. There's a lot of soft tissue work that has to happen. There's a lot of strengthening and constant stretching and constant mobility that has to occur until that joint kind of sets and settle, which can take a year or 2 years for the joint to fully get to a place of where it's yours. Your body has to accept it. You have to avoid certain things too, like falls and stuff like that, right? Now, I know I did this a little backwards, but I'm going to progress to the steroid injections now. Steroid injections of the knee are only the band-aid. They help with pain for sure, but at a certain point in time, they just start to eat at your cartilage in your joint due to the nature of the metabolism or the metabolic processes of the steroid in your system and how it metabolizes. So that's a cool thing to do. That's your preference. Just know as time goes on, eventually it's going to hurt more than it's going to help, and it will lead you to the replacement. Now, let's go to the left, all right? Besides over-the-counter medications, let's talk about the rehab portion. And the reason I want to touch on this a little bit is because I kind of feel like we're in a place where people just don't know. So it's my job to kind of educate maybe. When you're doing actual rehab for osteoarthritic knees, the grade has to be determined. The imaging has to be looked at. If you're a therapist, you're taught to be able to look at imaging and make some, common, understandings, right? Or some things that you can point out and say, hey, this is consistent with A, B, C, and D. I don't see this, I see that. As a result, I think the knee is in this grade or this state. So I'm going to approach it this way. And then considering the weight of the patient, also their activity level prior to the osteoarthritis becoming a problem to now, different things. But identifying the root of the pain. We have osteoarthritis, and we'll think that the pain is in the joint, and the pain is in the soft tissue surrounding the joint due to the actual inability or the 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 ability, the lack of wanting to move the knee. So there's a lot of soreness that sets up in the tissues around the joint, side of the knee, behind the knee, just all over. So a lot of our pain is not necessarily coming from the joint all the time, but we don't know until we touch it, right? And with that, you're on over the counter medication, right? It's going to help to a point. But the biggest thing to help with osteoarthritis is mobility. So in the rehab portion, prior to a joint replacement, when you're in a place you're trying to extend the life of your joint, there's some strengthening that has to occur. Your dynamic stabilizers, which are your muscles that help protect the joint, There's some modalities that have to occur. There's some soft tissue work that has to occur, and then there's a lifestyle change that has to happen. Whether that's dropping a few pounds, whether that's continuing the strengthening program, getting back into the gym, doing some more walking, whether that's doing some stuff to offset days where you're pretty rough on your knee, icing, heating, to maintain the health of the joint. The one thing I can promise you with um, just taking care of your joint and being attentive to its care is that if you do nothing, you get nothing. Straightforward. If you do nothing, you will get nothing. If you do something, you're going to get a response that's probably positive. And if you're not accustomed to actually doing any hard work, you're probably going to progress to the joint replacement, and then you're going to come out of joint replacement and realize you have to do even more work, and then you're going to be even more upset. So the truth of the matter is that you might as well work on trying to get as much out of your joint or trying to recover your joint as much as possible prior to going to the invasive route. Because sometimes a lot of it is just literally we're getting a little older, we're not moving as much, we have some stiffness because we do have some arthritis, early stages of it, and we kind of need to offset that with movement and mobility and some actual modalities and some rehab from time to time with therapists who are actually participating in your recovery, which does not happen all the time. We would like to thank everybody who's listened to this talk towards the end. And like I said, like, share, subscribe. Please check us out on Instagram, Facebook, YouTube. If you have some questions about what we do and how we do, you can contact us at 3GNIIGENPT2022 @gmail.com, or you can go on our website, the link below in the description, as well as right here, and just fill out our form to see if we can assist you or not. And I hope you all have a great day. With that being said, I hope you have a blessed one. I'll catch you in the next one.